Hello everyone, I'm Henry. Thanks for joining me. This is Chapter 15, Medical Care Reform in the United States. And guess what? It's the last video that we have for our class. Thanks everybody for joining. Next slide. There's been a really big push for reform in our country. So big, it's been happening since 1916. Every legislative session since 1916 has had one form or another of legislation to reform our medical care. 1 in 5 people want this reform. They want guaranteed access and they want it with lower costs. But can we really have guaranteed access with lower costs? The government thinks so, and that's why they keep trying to push trying to have the reform ever since 1916. Next slide. One of those things that we have to have when we're talking about medical care reform is we have to understand, is it a right or is it not a right? There are many people on both sides of the situation for this. And it's a very big moral issue that the American people have faced while they're having this conversation. What we have to understand is the Constitution does reserve the right to life, liberty, and the pursuit of happiness, but nowhere does it state that medical care is a necessary condition to exercise that right. And if we think that medical care is a right for us, then we're missing out on two different things that come into play, and those are the negative rights and the positive rights. The negative rights are also known as genuine rights. They're unchangeable, they're not man-made, and they cannot be destroyed. Where the positive rights are where we're extracting resources from the individuals and require them to act in a certain way or a certain manner in order to receive the medical care as a right. Next slide. As we're talking about the goals of reform, we have to understand that why we're here. And we're here because we have unlimited demands with limited resources. So there are 4 things that we need to talk about when we're talking about the goals of reform. The first is who is covered. Who is covered? Is it based on equal access? Is it based on equal health outcomes? Does equality equal everyone participates, or is it a voluntary basis? Next is what actually is covered. Is it a one-size-fits-all? Is it a tiered approach? Is it based on need? Then who defines that need? Is it the special interest? Is it the industry? Is it the individual consumer? Is it the legislatures? And then after we decide what's covered, we have to figure out who's going to pay. Okay, is it everyone? And when you say everyone, is it everyone as an individual? Is it all the companies? And then after we figure out who's going to be paying, we have to figure out how much they're going to pay, which falls back into who pays, because if it's every individual, is it a flat rate for everybody? Is it based on your income? Is it based on your employee status, your employment status, I mean? If it's all the companies, as we decided, and who's paying, if it's the companies, again, is it a flat rate for all, or is it proportional based on the size of the company? Next slide, please. Next slide. As we're talking about here, these are the options. As we're having these conversations through many, many years of reform, there have been 4 key things that have come into play, 4 key ideas that have always seemed to come to the forefront. And the first one of those is a single-payer health care insurance, which is usually known as the universal insurance coverage. The next is the mandated insurance coverage, where you're either mandating the employer to cover their employees, or you're mandating that the individual get coverage if they do not have insurance through their employer. And the key about the employer mandate here is that 90% of privately insured non-elderly people are already receiving health care coverage through their workplace. The third one that we're going to talk about is the market-based alternative. The market-based alternative, the market approach, and the reason why this is an issue is because the states feel like it's the government's fault for not creating the proper competitive market for the companies to be able to have their market approach. And the next piece is the consumer driven, and the consumer driven piece is where the consumers have skin in the game, where they're paying for portions of their, or if not all of their coverage of their medical care. And the next is the managed competition, where you have a subsidy that's given by the employer to the employee. Then if the subsidy is less than the actual cost of the coverage, then the employee can keep that. And if they don't put it in HSA or another healthcare coverage, then they will be having that as a taxable income. And if the premium is higher than what the employer is giving as a subsidy, then the employee has to pay the difference. So we do have these 4 key choices that have been popping up during the conversation. Next slide, please. The next slide here and the next couple of slides, we're going to be talking about the Patient Protection and Affordable Care Act, which is also known as the Affordable Care Act of 2010, and some people also call it the Obamacare of 2010. It was 2,400 pages, but don't worry, if you want to read it, they've broken it out into 10 sections for you, so you'll have no problem reading it. But in the Affordable Care Act, there are 5 key provisions that I want to bring out into it. The first one is where they've expanded the regulation of private health insurance markets. The next one is where they've expanded the Medicaid eligibility, and the states have to have the choice if they want to expand the Medicaid coverage or not. Then the third one is where they're using the actual Medicare revenues to fund the coverage expansions for the non-Medicare recipients. Next is they're creating new federal taxes to help pay for it. And the last one is where they're inserting the government-favored insurance options into the private health insurance market. Next slide, please. Excuse me, I apologize. Some more pieces about the Affordable Care Act is the Congressional Budget Office. Their estimates in 2010 for the expenditures, it was proposed to be below $900 million, but the actual spending actually estimated to be $1.19 billion. And in 2012, the expenditures were actually estimated to be at $1.2 billion. One of the unintended consequences that have come from the Affordable Care Act of 2010 is something where it was proposed in the beginning where if you like your health plan, you can keep it, and that hasn't worked out to be the case. 14 million non-elderly people will lose their insurance cover by 2019, and up to 93 million seniors will lose their private health insurance, according to the Health and Human Services. And as we're trying to provide a sustainable market-based solution, we need to understand that there are 4 core problems that our system faces that we need to address. The first of those is it's designed to minimum adverse selection. The second one is we have too many uninsured Americans for it. The third is we have too few little insurance companies, so we don't have enough competition to make it beneficial for the insured. And next, as we all know, there's high litigation leading to medical professionals, doctors, physicians, medical groups to practice defensive medicine instead of actual practicing medicine. Next, we're going to be next slide, please. Here we're going to be talking about the state level reforms. There have been 4 states that have tried some form of another of their state level reform. The first one of those is Hawaii. Hawaii has a universal coverage where it's mandating employers to have employer-based health insurance. That's been around for 35 years. The Oregon Health Plan is a Medicaid experience where there is deliberate rationing of services, but surprisingly there's been little opposition to this health plan in Oregon. Next is the Massachusetts plan, where they have crossed party lines to increase coverage and improve quality of care with a sustainable cost structure through the individual mandates that we mentioned earlier. And last is the Tennessee, where they've created a health plan reform for the uninsured population to control Medicaid spending. And next, the next couple of slides, we're going to be talking about the lessons that we've learned from these states. Next slide, please. The first of these lessons is that we have universal coverage is very expensive. The state finance programs will crowd out private programs. Next is more costly. It's more costly than the original estimates, as we mentioned earlier. The second thing we've learned is legislating the definition of a full-time equivalent employee will create an abundance of part-time employees, so you'll have a lot of people going from full-time status to part-time status. And on the track of universal health insurance coverage, it's going to be difficult politically to go back off of that once we started down that track. The lesson 4 that we've learned from these individual states is expanding coverage to more people will lead to rationing care, as we mentioned earlier as well. Next slide, please. Lesson 5 that we've learned from the states is that it's simple to expand the coverage for free with free and or heavily subsidized policies, but the cost pressures later on will cause the undermined early gains to be minimized or nullified. The sixth lesson we learned is the first step in cost containment is to move away from our current fee-for-service stature to the global payment methodology. The seventh lesson we learned is that one-size-fits-all benefits is expensive, and it pressures to expand the coverages are very enormous as we go there. And lesson 8 is the physical realities of expanded coverage may require scaling back of basic benefits than what they would have for standard policies with private insurance. So what that's stating is that these basic benefits will be less on the government control plan than it would be for the private health insurance coverage that they could get. Next slide, please. As we see here, here's the references that I'm utilizing for today. And our question for today on the next slide will be, do you trust the government enough to have them run the healthcare industry in a single payer system with no other option for health insurance coverage? Thank you for joining, and I hope you have a great day. Bye-bye.